Okay, so this is part 3 of our bones and skeletal tissue lecture. And just to wrap things up, I wanted just to touch base a little bit on this fact that bone is very dynamic. And so we've talked about this before. We talked about how the entire skeleton is replaced like every 10 years of your life. Bone is not static. They're not static structures. They're constantly remodeling. And what we like to see is that the rates of bone reabsorption and bone deposition, so breaking down bone and creating bone, are basically equal, because then we end up with good, strong bones that are not likely to have stress reactions or break or that sort of thing. The skeleton is continuously remodeling, and typically we see remodeling occurring at the endosteal surface. So kind of that interior surface of breaking down and building up. We have two ways that bone remodeling is controlled. And the first way is going to be through hormones. And so this basically takes into account the fact that our body likes a typical homeostatic level of calcium in our bloodstream. So we like to keep our calcium at a certain level. And so if we have our blood calcium levels, fall below that level, if our blood calcium levels, my cursor is acting a little squirrely. Let's see. Let's get rid of this. Okay, so if our blood calcium levels decrease below a certain amount, that's going to stimulate the parathyroid gland to release parathyroid hormone, which is then going to obviously increase our levels of parathyroid hormone circulating in the bloodstream. That is going to stimulate osteoclasts, which we know is the particular type of bone cell that breaks down bone. And when bone is broken down, it releases its stored calcium. Bones are our primary way of storing calcium in the body. And so when we break that bone down, we end up releasing the calcium into the bloodstream. And when that happens, our blood calcium levels are going to increase, back up to that normal level that we like, and the whole thing's going to shut off, just like a typical negative feedback loop that we see in the body. So remodeling helps keep calcium levels in the bloodstream relatively constant, but we also have a second type of remodeling, and that's in response to stress. So here's our remodeling due to mechanical stress. And this uses this concept of Wolff's Law. And this is the fact that your body, and specifically your bones, will respond to mechanical stress. So the more stress you put on bones, the more remodeling, the more building up is going to happen. So we see this in a couple different ways. Number one, we see that bones of dominant limbs tend to be thicker. So if you're right-handed, your right arm tends to be a little bit bigger. Maybe rings that would fit on your left hand don't fit on your right hand because your right fingers are a little bit bigger. And that's because of Wolff's Law. That's an example of Wolff's Law. We also see trabeculae, so those kind of bony spicules within spongy bone, which we're going to see more in the epiphyses of the long bones, right? So more at both ends. The trabeculae are going to form lines along areas of stress. So they basically realign in areas of stress. So for instance, if we had, this is it looks like a humerus here. Oh no, this is a femur. when we put stress on areas of bone like this, you can see this area right here would undergo more compression. This area on the outside here would undergo more tension. And so we're going to see a building up of bone here to accommodate this compression. We're going to see a building up of bone here to accommodate the tension in response to the stress that's placed on that bone. And then this is the whole reason why we see bony projections where muscles attach, because those muscles pull on bone and cause the bone to lay down extra bone in that area as a result of that stress. So when you see, bony projections on bone, those bony landmarks that you can feel and learn the names of, that's because of Wolff's Law. When muscles pull, it stimulates your body to lay down extra bone. And this is the whole reason why older people need to stress their bones too, so that they don't develop pathology like osteoporosis. They need to do weight training. They need to do weight-bearing exercises, so like a lot of walking and that sort of thing, so that their bones will be stimulated to lay down more bone. And then we can talk a little bit about fracturing bones and stages of repair. So what we see with this, when you fracture a bone, it is important to note that bones are highly regenerative. We do heal when we break, and that's a good thing. But the first thing that's going to happen is we're going to form a hematoma. So you're going to have bleeding within that bone, because bones are highly vascular. We've got that nutrient artery that's traveling into the bone and dividing, and bones bleed. When you break them, you tear those blood vessels, and you're going to form a hematoma. The second step is we're going to form a fibrocartilaginous callus. And so basically, after you have a break, you're going to have a migration of fibroblasts and chondroblasts into the area. And fibroblasts are going to secrete collagen, chondroblasts are going to start secreting cartilage, and they form kind of this initial callus made of fibrocartilage material. The third step is going to be replacement of that initial fibrocartilage callus with osteoblast secreting kind of more of an osteoid, like a immature bony matrix. So osteoblasts in the area are going to come in, and they're going to replace that fibrocartilaginous callus with bone. And then we have a period of time where the bone remodels. And so you're going to see a remodeling of the bone based on the stress that bone is under, the normal stress. So that happens for months after the bone fracture is healed. And what you end up with at the end is a bone that is pretty much as strong as the first bone that was broken. And you're not likely to break it again in that same area. I think that people think that, but I don't think there's been any research to support that. So it heals back, it's strong, and if you place the same stress on it again, it remodels, and it's able to do what you need it to do there. So some types of fractures that we see in bone, comminuted fracture, and you can certainly read through these. These are fractures that break bone in lots of different pieces, so it's going to be like 3 or more pieces that it's broken into. Compression fractures basically happen when you have compressive stress on bones that cause them to break. So we see this like in the spine of older people with osteoporosis. Spiral fractures result when you have a twisting type injury. So you'll see this in sports injuries. Here's the epiphyseal fracture that we talked about earlier, where you have a break along the epiphyseal plate. So you see this in kids when their plate hasn't closed yet. A depressed fracture is basically when you have part of the bone that's basically broken and then has moved kind of inward. So this would be kind of a, you know, getting whacked on the head with a baseball bat or something like that. It's like a depressed skull fracture where that piece of bone has kind of broken inwards. Green stick fracture is commonly seen in children, and it's where the bone doesn't break completely all the way through. You typically have some kind of tearing of the bone towards the outside, but then the other side stays pretty much intact. And we see this, it's more of like a fraying, kind of like what you see with sticks. Like if you picked a stick off a tree, that's why they call it green stick fracture. Pick a stick off a tree and kind of bend it, and it kind of frays on the outside. That's what this type of fracture looks like. And you see it more in kids because kids have a higher collagen content to their bones, so their bones are a little more bendy. They have less mineral salts, less of the inorganic components of bone that make your bone just really, really hard. So because they're a little more bendy, they don't necessarily break all the way through, but they tend to fray. And I just wanted to show you a couple radiographs. So this is showing you here's your fracture in the fibula, and you can see that there. And then when the bone starts to heal and you get that replacement of the fibrocartilaginous callus with bony tissue, this is what you see here. So here's your initial bony callus that starts to form, and then it will be remodeled and won't look quite so big after the remodeling. Here's an example of an internal fixation. So this person had a pretty significant fracture to their tibia, and they'll go in and put some hardware in. So you can see they've kind of got this plate, here, and then you've got screws where they've gone in and they've kind of screwed it into the bone. So that's what happens when you need some more fixation, and maybe even smaller pieces that the body can't heal on its own. Here's a fracture. If you can see, this is a femur, and if you can see kind of this line here, there's your fracture line, and here it is on the other side. And so this is a fractured hip, and what they do is they'll go in and put one rod down kind of the long shaft of the bone, and this is actually going into the medullary cavity of the bone, and then they'll put another internal fixation piece going the opposite direction to be able to hold the head of the femur onto the rest of the femur. And this is how they can do an internal fixation of a hip fracture. And then this last one is showing you external fixation. So this guy has probably broken femur, maybe right around here. And typically what they'll do is they'll put pins in proximal to the fracture site, and then some pins in distal to the fracture site to hold that fracture site stable while it's healing. These people are out walking around. They'll even come to therapy with these external fixation devices on, and we'll work with them, and then eventually they'll get those pins pulled out once the fracture heals.